Welcome back. Clinicians who treat Alzheimer's patients have new medications in their arsenal. This panel will delve into their experiences, including conversations with patients and care partners, understanding the benefits and risks, managing side effects, and adapting their practices. What insights have they gained in treating people with these drugs? Let's talk about that now with panel moderator Russ Paulson, Chief Operating Officer of Us Against Alzheimer's.
Welcome to our panel on something that we're very excited about, a disease-modifying therapy in Alzheimer's disease, something that people have been working on for decades, finally became real a little over a year ago. We wanted to have a conversation with people who are actually using the drug with their patients. So today I am joined by three experts, two from the United States and one from Japan, to talk about their experience with lecanemab. First off, all the way from Japan, and thank you for staying up late at night, Dr. Ryoko Ihara. Dr. Ihara, maybe a quick introduction.
Hi, my name is Ryoko Ihara, a neurologist at Tokyo Metropolitan Institute for Geriatrics and Gerontology, Japan.
Thanks. And from Hattiesburg, Mississippi, Dr. Wendell Helveston.
Yeah, I'm Wendell Helveston. I'm a general neurologist delivering neurologic care in a rural healthcare setting in Hattiesburg, Mississippi.
And finally, Dr. Suzanne Schindler.
Yes, I'm Suzanne Schindler. I'm a neurologist at Washington University in St. Louis, Missouri.
All right, thanks all. And we'll try to do this as much of a discussion as we can, but I will call on some of you occasionally just to sort of get things started. The drug has been out for a little while, and Suzanne, I think you have more patients than anybody on this call on lecanemab. Maybe just a little bit about what that's been like for you and for your patients. Anything surprise you?
So at Washington University, we've been very involved in clinical trials for many years, and we have a lot of providers. We have 16 different providers, and we were all very excited about being able to slow progression and finally provide our patients with a disease-modifying agent. So we were ready. We had patients teed up and ready to infuse pretty much as soon as the drug was approved. So we started infusions within a month of lecanemab being fully FDA approved. And we now have at our center over 200 patients that are receiving lecanemab. And in terms of adverse events, they've really been completely in line with what we expected from the clinical trial, the large clinical trial of the drug that led to its approval. And we've done a lot of work to figure out the logistics of infusions, and also just the evaluation process. It's really quite an undertaking, and it's required us to change the way that we kind of practice medicine. But we feel like we've been successful in making it work. So we're overall happy with the way that it's gone, even though it's been a lot of work. And we're continuing to increase our number of patients, which attests to the fact that we think this is working.
And Dr. Ihara, how is it in Tokyo?
Mm-hmm. Almost the same as Suzanne. I have been involved in clinical trials of anti-amyloid antibodies for several years. And in Japan, lecanemab was approved in December last year. And we are now using lecanemab for 75 patients. And of course, we experience some adverse event, but not so severe for now. So, but the largest barrier to extend lecanemab use is limitation of space for infusion. That's a big problem.
And Dr. Helveston, you practice in sort of a different context than either of these two doctors in the big medical centers.
Well, yeah, we do. I have two other partners at this location. We do not do clinical trials, but we had an active infusion service with 8 beds before the approval of lecanemab. We infuse MS drugs and things for CIDP like IVIG. We do headache infusion. So we had a lot of experience with infusions and with running an infusion center. So we started doing more biomarker testing, and like the physician in Washington University, we had patients that were basically banked up from doing biomarker confirmation. So we were able to get a quick start. We've got about 65 on for our 3 docs.
So we all talked about sort of the risk of adverse events, and ARIA is the thing that people worry about. And Dr. Ellis, I'll start with you. 65 patients. What's been the experience with ARIA so far?
Our experience has been absolutely conforming to the clinical trial and to the package insert information. Our numbers are right down the middle with what we expected. It is interesting. We focus a lot on the potential ARIA and side effects from treatment, but on the effect side and on the positive side, we feel like we've had some really good stabilization in some of our patients we have treated. So the good thing is that we've seen patients stabilize and it's pretty well tolerated. We have seen our share of the ARIA cases, but overall, our experience has been that it's the risk benefit seems to be in a good place for this drug.
Talk about what your experience with ARIA. What's that look like? Have you had anybody who has been seriously sick with it?
I haven't had anybody that's been seriously sick. We've had a few people that have come in with headaches and a little bit of confusion. We did scans outside of the normal protocol scans, and they had new ARIA. I've had one case that had both microhemorrhages and edema, ARIA E and ARIA H. We've had to take a couple of patients off, but generally they've been asymptomatic. Most of them have been caught in the protocol scans.
And how about you, Dr. Ihara, with ARIA, and what's it like? What's it been like for your patients?
I experienced 5 ARIA patients for now. One is mild ARIA E, and one is mild ARIA E combined with moderate ARIA H, and 3 ARIA H, mild ARIA H. Everyone is asymptomatic. Every ARIA was found in scheduled scan. Actually, frequency of ARIA is lower in Japanese population in clinical trial as well.
And are they all resolving? The ARIAs?
Still, we are observing.
Yes. And Suzanne, out of the 200, what's the ARIA picture been like at WashU?
So we have 154 patients who've had at least 4 infusions in their first monitoring MRI, which is typically where you pick up ARIA. And out of that 154 patients, 30 have had ARIA. So about 20%, which is what was reported by the trial. However, it's important to note that 20 out of those 30 were mild ARIA. So if you have one teeny little microhemorrhage or one very small area on T2 hyperintensity on a scan, that counts as ARIA. So the threshold for ARIA is extremely low, and so that's why we're picking up, that rate of cases. And out of those 30 individuals with ARIA, 7 were symptomatic. And as we've heard about, the symptoms are often things like headache or confusion. 4 of those have had mild symptoms where it really didn't affect their life, their everyday life. 1 had moderate ARIA where it did have some impact on their activities. And then we had 2 people with severe ARIA that we hospitalized. And so we do take this seriously, but I think it's important just to provide the context that we're talking a couple % of people that have more severe impact. And so we're continuing to monitor people, but most people are tolerating it quite well. And of course, you don't hear about all the patients that are doing just fine and continuing to get their infusions every couple of weeks without any events.
I would like to make an observation without data. I think that we've seen a few more ARIA cases in patients that have lower scores on bedside testing. I think the patients that are on the upper end of the spectrum seem to have, and that's just a general gestalt feeling. I think we've had a few more in cases that have, minimal metastasis from 23 to 25 than we have in patients that are a little higher. That's my impression. Early patients, I have not had, I think, as much ARIA.
And in managing the ARIA, Rilke, you said it's all been asymptomatic, but where you've had symptomatic ARIA, and Suzanne, you had 2 who had to be hospitalized. I guess maybe let's talk about the ones because people worry about this. The folks who get hospitalized, what's the treatment for them? What's their course?
It depends on what their symptoms are. In some cases, we have been treating patients with steroids. So those 2 patients did get steroids. However, there's really not a lot of data on whether the steroids are actually effective. And I have had other patients who are participating in clinical trials where we didn't treat them with steroids and they did just fine. I just recently followed up with someone who had severe ARIA 5 years ago, and she's doing amazingly well. She's really not much different than she was 5 years ago, which is pretty remarkable. Of course, anecdotal, but just interesting. And so in her case, she had seizures. And so she was treated with anti-seizure medication. So it really depends on what the exact scenario is, how we treat them. But in general, the symptoms typically resolve after a couple of weeks. Some patients do need to go to rehab, and we just keep following them up and dealing with issues as they arise.
Dr. Hellison, for you, the ones with the headaches, do those resolve without any kind of treatment, or do you have to do something?
We wrote them out. Yeah, we did not use dexamethasone or any other steroid. We watched the patients over several weeks and had symptom resolution relatively quickly, and then rescanned them about 6 to 8 weeks later and saw the beginning of resolution of the ARIA. So we just wrote it out with the patient.
So given everything we've talked about, and there's definitely a lot of conversation about ARIA in the field. But as a couple of you pointed out, there's not been a lot of conversation about benefit. And certainly when you're talking to patients before they decide that they want to do this treatment, you have to have a conversation about risk and benefit. So I'm curious how you talk about risk and benefit, particularly with a drug where the benefit is not suddenly you're better, it's that you get worse more slowly. So how do you all have that conversation? And I'll start with you, Dr. Ihara.
We talk about benefit of 27% reduction of disease progression and risk of ARIA and infusion reactions, and also cost and visit burden. So Japanese people tend to put more importance on safety. So some patients refuse lecanemab treatment because of ARIA. But many patients do not matter, do not risk of ARIA does not matter to many patients.
So Suzanne, how about for you? What's that conversation like?
So this is a conversation that we've actually been having for many years with our patients because we've been using a medication called donepezil, which also does not help patients get better, but it has been shown to slow the decline in terms of their symptoms. It's not a disease-modifying treatment. And so we're used to talking about a slowed rate of decline. And it's actually really important that patients have very clear expectations. So I'm clear this drug is not expected to make you better. This drug is expected to slow progression of decline, and that we see that there's clearly a rate of decline. We think that it may add about 6 months or in terms of additional function, potentially, but that rate of benefit varies across individuals. And we also talk about how they have been selected based on certain criteria because we think that they are a person who may benefit from the treatment. And they have a more favorable profile based on a variety of different criteria. So we really try to personalize our care for patients. And we really talk to them about risk in terms of that we do see that, X% of patients have side effects, and these side effects can include things like brain bleeding, but these are typically tiny dots of blood. These are not large hemorrhages. I think it's important to make that distinction because when people talk about brain bleeding, they're often visualizing something completely different than a microhemorrhage. And also with brain swelling, we see little areas, and in most cases, that are consistent with brain swelling. However, they actually look pretty similar to changes that we often see with normal aging. And we see that, especially with the brain swelling, that typically resolves after a couple of weeks on its own, usually. So it's a long conversation, but I try to go into as much detail as possible about these risks, because if you just simply call this brain bleeding and brain swelling, it actually is misleading. It really does not accurately describe what the true side effects are. Also, I do think it's important to say that the death is a possible side effect, but it occurs rarely. And the data that we have so far suggests that this is maybe 1 out of 1,000 patients. So we're talking 1 out of hundreds to 1 out of thousands. So it's a potential risk, but it's not a huge risk. And again, I think that providing as much detail as possible is important. And another factor is ApoE genotype. So people who have 2 copies of the ApoE epsilon 4 allele are at much higher risk for side effects. And so that's a key factor in this. Either you have this genotype, and so we think you're at higher risk. And we're still treating people at my center who have E4 homozygous status, but we're very clear that their risks are higher. Or you don't have this, and so we actually think you're at lower risk for complications than people that were in the trials. So this is a pretty long, complex conversation, and everyone has a different level of risk that they're willing to endure. And so we really try to make sure that we are making decisions that are aligned with the patient's values.
Dr. Helveston, how about for you?
Well, my experience has been that the patients are, we do the same process. We give the risks, the benefits. We talk about their APO status and how that affects their risk profile. But it's impressed me that the patients and families are willing to take on risk in the pursuit of having a slower rate of decline. Many of my patients have told me that their number one fear is being unable to care for themselves or have to be displaced from their current home or setting that they're living in. So they're willing to take on risk for the potential benefit of slowing the disease process. These patients are older and they understand that risk up to and including even death, it's really a serious and bad thing. But if they feel that we can slow the disease process down a little bit and buy them a little bit of time, they're willing to trade that risk. They're willing to do that more so than I thought they might be willing to do. They step up and they're in there wanting to give something a try. I think it's interesting. Most of these patients have a family member, a mother or father that they've watched go through the decline with Alzheimer's disease, and they realize what a serious diagnosis this is. Alzheimer's disease, I think that the neurologists and the doctors, we know it's a horrific and progressive disease. And patients that have had family members, they know that too. And I think we need to recognize that people want to try. They want to try. They want to make an effort to slow things down.
Dr. Hara, how you mentioned that some people, after having the conversation, choose not to, and others choose to. Any sense of how patients and their families are making this decision in Japan, whether to go ahead or not? What's the deciding factor?
Let me add one thing.
Yeah.
We are using informed consent form, which consists of 4 pages, and just a squeezed version of informed consent form of clinical trial. And some patients consider there is a large risk for small efficacy. Those patients do not choose lecanemab. But for many patients, many patients do not take it very seriously. Those patients choose to use lecanemab.
And when you say they don't take it seriously, they don't say more about they don't take it seriously.
Yeah, I will add some explanation about risk, but some patients still do not take it seriously.
Okay. And I'm curious about the benefits. We've talked a lot about risk. We've talked about sort of risk benefit. Suzanne, you mentioned you had somebody who had pretty significant symptomatic ARIA 5 years ago who is basically the same. What's your obviously if lecanemab was all about risk and not about benefit, and nobody'd be wanting to prescribe it, and yet you're still talking to patients about it. What's sort of driving you, Suzanne? And then I'll come to the rest of you, but what's driving you to say this is something you ought to consider?
Well, I think one thing that's driving us to consider this is that we know what's going to happen to the patients if we don't treat them, because we see patients, once a year, sometimes more than once a year, and every time we see them, they're worse, and they get worse and worse until they die. And it's also very distressing for their families because their loved one just becomes more progressively impaired. It's a really awful disease for everyone involved, the patient and the caregiver. And what the clinical trials have shown, and I think in a very clear fashion, is that the anti-amyloid treatments do slow progression. Obviously, we would like something that cured people and made them who they were before, and that's not reasonable expectation. But we do see with these treatments that they do slow decline, and you can debate about whether it's a meaningful amount or not over 18 months, it slows it down about 6 months. And I think, at least for me, I think that that's a meaningful change. One question that I think all of us have is what's going to happen at 5 years? If I treat them for 5 years, what are they going to look like then compared to if I didn't treat them? Of course, companies are trying to develop that data, but I think that that is actually part of the reason why we're treating them is we generally as doctors know that if you catch a disease early and treat it, that people do better in the long term. I don't really see why this would be any different. So I'm hopeful that we will see that people are doing better many years out. Of course, we have to wait for the data to know for sure. But I think that is part of what we're thinking about when we start people on these drugs.
And how about you, Wendell?
One thing that I sometimes do with the patients is we have a discussion and they will tell me, let's try it. Let's try it. I want to try. I want to see what the burden of having to come in and get the infusions every 2 weeks looks like and how hard that is on my family and how I feel like I'm responding to it. Let's try. I've had lots of patients that have done that. We have a lot of patients that are stable with their disease. As Susan said, they're stable. They're doing well. So I've had more than a few patients that say, because this is not a lifetime contract that you have to be treated no matter what, right? They can give it a try. If they don't like it, they can drop off. It's not a cure. It's a treatment. And so they'll try and we'll go forward. And if they do not like it, we'll stop. If they want to continue on, we continue on. The good news is many of the patients feel and their families feel that they have stabilized and they opt to continue on the treatment long term. Some drop, many, the vast majority continue on. And that makes me think that our efficacy as defined in the clinical trial is going to be correct with this drug post-marketing.
And you are the general neurologist of the three of you. So talk about how this is compared to other neurological diseases where there isn't a cure, but there is a treatment and it can have a burden on a patient.
It's very similar in a lot of ways to some of the early treatments for multiple sclerosis. They didn't have screaming efficacy, but they worked and they slowed the disease process down. And then as time went by, we got more and more efficacious treatments for multiple sclerosis. It's kind of similar in that respect to that other disease process with MS. It's very similar to that. And in terms of risk, we frequently treat other diseases with drugs that are a lot riskier, really, than lecanemab. Things like Tisabri for multiple sclerosis has a significant risk of side effects with treatment. So it's almost, and you can compare this therapy for Alzheimer's disease with some of the treatments that the oncology groups use, right? So they use drugs and they talk about response rates. They don't always talk about cures. We are palliating this disease, but we are, I think, doing justice to the families and to the patients by giving them an option and giving them something that they can try to fight the disease with.
And Dr. Ihara, in Tokyo, what's that like in terms of patients and their burden and thinking about this versus other potential therapeutics in other areas?
But the lecanemab is the only therapeutics for MCI patients. So MCI patients cannot select treatment. So people with MCI usually do not refuse treatment, lecanemab treatment.
They choose because there is no option for them.
No options.
The option, I guess, is that they get worse. Like Suzanne was saying, they get worse and worse.
Yes.
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 Okay. So, talk about the conversation, and Dr. Ihara, we'll start with you. The conversation, sort of, how do you get to the point where you're ready to have the conversation? Because not everybody who comes in with some kind of subjective cognitive complaint is going to be someone you're going to suggest that we consider lecanemab. What's the funnel like there?
Usually, people come to my hospital with willingness to use lecanemab.
So they get to you when they're ready.
Yes, they are ready.
And have they been referred to you by other physicians then? Yep. Okay. And Wendell, you probably don't have a big apparatus of other physicians referring, but I imagine a lot of people who do come to your clinic have been referred by other physicians there in the community.
That's true. We're getting two things. We're getting referrals from primary care, family practice, internal medicine doctors of patients that they suspect have dementia. We're getting those, but we're getting more and more self-referrals from a younger patient group who have parents or grandparents that have Alzheimer's disease, and they want to be evaluated because they have many times high cognitive baselines, and they're starting to notice maybe things are not quite right, and they have a lot of fear of Alzheimer's, having seen family members go through the process of decline and sometimes death due to Alzheimer's disease. So we're getting referrals from both areas, and I have a tendency to work them up now that we have a treatment. You know, when you have a treatment, active treatment for a disease process, you don't want to miss cases, especially in a drug like this that has a clear treatment window. If you wait and don't make the diagnosis and keep watching the patient for a long period of time, they'll drop out of the treatment window and you don't have a shot at therapeutics for that patient. So our tendency, and my particular tendency, has been to go ahead and have a lower threshold to get the patients evaluated with biomarker testing to identify cases so that we might offer them the option of monoclonal antibody therapy.
So what's the workup look like?
In my patients over 65, they get obviously bedside cognitive testing and MRI, amyloid PET, and then routine serum serologies. That's the classic workup for Alzheimer's. If they're younger, I'll probably and generally get neuropsych testing, and frequently we'll do serum biomarker testing before we might progress to amyloid PET prior to. Just depends on the patient's age. And a lot has to do with their insurance payer status. Will their carrier cover advanced imaging, or will they simply cover serum testing? And frankly, I have a significant number of patients, if their insurance will not pay, especially for serum testing, they will come out of pocket for serum testing because they want to know the answer.
And how do you treat people who are on other medications, the antiplatelet meds, those kinds of things? What's your criteria on that?
Antiplatelet meds don't slow us down very much, and in the clinical trial, they did not have a significant effect, for antiplatelet therapy. We have long conversations when they're on anti-thrombotic therapy with other drugs like Eliquis. You know, we have significant conversations, and many times we'll send them back to their cardiologist or their internist and do what we can to get them off those drugs to give them better options and lower risk profiles before we start treatment with lecanemab.
And Suzanne, how about for you? I know you have a pretty, you mentioned earlier, you had to put a lot in place at WashU to be able to sort of treat the right patients at the right time. But can you talk about the workup and qualifications and what it takes, that conversation that we talked about? What does it take to get to that conversation?
So it's actually a pretty time-consuming process. So we do the initial evaluation, very similar to what Dr. Halverson was talking about in terms of we do a detailed history, we do a neurological examination, cognitive testing, we do routine blood work and structural brain imaging like the non-contrast brain MRI. And then for patients where we think they may be a candidate for anti-amyloid treatments, we do biomarker testing, and we are right now using all three modalities of clinical biomarker tests for Alzheimer's disease. So we're doing CSF testing, we're doing amyloid PET, and we're doing blood tests. So we have to decide which modality we think is best. It just depends on a variety of different circumstances. And then if all of this, again, indicates that they're a good candidate for anti-amyloid treatments, then we do ApoE genotyping, and that informs us about risks and benefits of treatment. So this takes place over multiple visits, and we actually have a dedicated treatment clinic with a physician assistant and nurse practitioner that help to complete all of these tests and talk with the patient about this. Just returning the results is quite time consuming. So it's a long process just getting to the point of having that discussion about risks and benefits of anti-amyloid treatments. But we typically are able to do it over a few months. So this is not an overnight thing. So typically happens over a few months. And then we have that conversation about treatment, and then that sometimes takes some time as well.
I say this, I have to comment on this. I think that if you work patients up and they are negative for their biomarker testing for Alzheimer's disease, it is not a complete waste of time. It buys the patient a great sense of confidence and relief. If they believe that they might have Alzheimer's disease and you work them up appropriately and they rule out for Alzheimer's, it is a very reassuring thing to the patient if they do come back negative with their workup. So it's not a failure to evaluate a patient and have negative testing. There is clinical utility there, and we would expect that some of the patients who we evaluate will in fact come back negative, and that's an okay thing. I have to say that.
Do you sometimes find reversible causes, B12 and other?
Yeah, B12 deficiency, thyroid problems, you name it. And sometimes you diagnose other types of dementias like vascular dementia and you catch those on the MRI. So in the process of the evaluation, A, you do find other causes for dementia, and B, you can reassure the patient if you don't find anything. All the above.
Suzanne, that's your experience as well?
Yes. So of the people who make it to biomarker testing, about 70% of them are positive, which means about 30% aren't. And in many cases, that negative result is very informative. They still have something going on. The frustrating part is that we don't have good tests for many other disorders, so we can't definitively diagnose things like late, which can look a lot like Alzheimer's disease. But it is quite informative, and we frequently find other issues that are going on that we can help. And it's actually wonderful to be able to find those because patients can get better.
Dr. Helps, you said a while ago, you had patients said, let's give this a try. And one of the things you mentioned was, let's see how it is to come in every couple of weeks for an infusion and every so often for an MRI. What do people end up feeling like? How much of a burden is coming in every 2 weeks and coming in periodically for an MRI?
It is our area, our average drive time into clinic's about an hour one way. Okay. So it is a burden. And I've had a couple of patients that have experienced infusion fatigue and they dropped out. My approach has been to get them stable. Okay. And if possible, we like to get them to that 14th treatment and get that the last MRI out of the way. And then I like to roll them over to home infusion services that can come to their home and infusion in their environment if possible. And then, of course, hopefully at some point we'll get relief on maintenance dosing and or a sub-Q formulation. We don't know about that, but maybe in the future we'll go there. But right now, I try to get them stable, get all the MRIs done, and then roll them off to a home infusion service where they don't have the burden of the travel. That's kind of been our approach.
And Dr. Ihara, in Tokyo, people probably have to commute quite a ways to get to your hospital as well. What does the burden feel like to patients, and how many sort of say this is too hard?
Yeah, actually, I emphasize the visit burden most when I explain lecanemab treatment. But patients, for patients, it does not matter because many old patients love to see doctors. So, because co-payment rate is very low in Japan, so it doesn't cost matter. It doesn't cost much. So many patients love to see doctor.
And Suzanne and Dr. Schindler in St. Louis, what's your sort of dropout rate from people who say this too hard?
It's pretty low. We do have some people who've dropped out. Interestingly, we've had a couple people who have dropped out not because of ARIA, but because of fear of ARIA. Because they're just so worried they're going to get it, and they never do. But they're just very anxious about it. The infusions are a burden more for some people than others. In St. Louis, we have a lot of different infusion centers all over the place. And so some people are lucky in that they have an infusion center nearby and it's not much of a burden, but other people have to drive. And so it takes a longer portion of their day. And for some people, they have to have a caregiver take them for an infusion. So that creates a bigger burden. But some of our patients are very mildly affected and they're still driving. So they drive themselves in some cases to their infusion and that they feel like it's not a big deal. So again, it really depends on the individual.
There is a fascinating phenomenon, and I don't know if I'm sure everybody has observed this that has infusion chairs. There is a community that the patients bond in the infusion center, and they form a little community in the infusion center. They visit, they talk, they watch TV together, they get their medications together, and it's a fascinating thing in that a community forms there, and they actually enjoy the community aspect of the infusion center. The nurses pay a lot of attention to them. They track the patient. So that's pretty fascinating that occurs, but it does occur. We've seen that over and over and over. What about the other? Do you guys see that as well?
We actually, I have heard about that from some patients. So we try to schedule them for the same time every 2 weeks. And so they're often with the same people. And I have heard about that. They've made friends with people getting infusions at the same time. So it is interesting.
Yeah, that's a fascinating phenomenon, this bonding that occurs.
So these drugs, first of their kind in Alzheimer's disease, there's a patient burden that goes with them, both in terms of coming in, lots of MRIs up front, lots of workup up front. Benefit is, I think of it from a patient perspective, as 6 months or so. We don't know if it's more. I don't think that the 27% means a whole lot to patients. So as patient advocates, we think of it as a six-month thing. There's some physicians who sort of want to say, not good enough. I don't even want to offer this to my patients. I wonder if you had them in a room, what you would say to them.
I would say that it's really not their decision to make. I think they have to, if a drug is FDA approved and the drug has data, I think you have to, in my opinion, you have to at least have the discussion, give the patient the numbers, and let the patient make their own mind up. Okay, I don't agree with the approach of I know better, and the patient's not capable of absorbing the information and making their own informed decision. That's not been my approach. I don't necessarily agree with that approach. But that's me.
So sometimes patients ask me, so if I were your, father, mother, would would you treat me? And I think what they're really asking is for someone that you really, really care about, what would you do? And they want doctors to really care about them and think about this. And at least for me, I think that if my mother, father, someone I really cared about deeply had this disease, I would treat them. And and I think I would be very unhappy with people who were not even considering that, just taking that off the table. Um, Sometimes people use kind of war analogies with diseases, and there's debate about whether that's appropriate or not. But in some ways, it's a battle against a disease, and this is one weapon. And you want a doctor who is considering everything and all the tools that are available, and just completely dismissing this as an option, I think, is a mistake. On the other hand, this drug is not appropriate in all patients. Um, and so, really, the key is you have to look at the patient that's right in front of you and decide, is this appropriate or not? Is this going to help them as they're contending with this disease? And yeah, I think it's a mistake just to completely dismiss it. I think if you do that, you are not, for some patients, you are not looking out for their best interests.
What the question to ask is, and I actually asked it at a round table of several memory disorders experts, and there were maybe 10 there around the table at lunch, where is where you get the best conversation. I asked everyone if by some happenstance you were found to be biomarker positive for amyloid, would you be treated? Would you take the risk of ARIA to be treated to slow down your disease? And there was a total consensus that the answer was yes. Okay. So the real question is, if you, doctor, by some, again, happenstance, were diagnosed as being amyloid positive, MCI due to Alzheimer's disease, would you be treated? The answer generally in that group is yes, they would be. And I think because of that, I think it's a little bit unfair to take that option off the table.
We are right up against time, but I want to give folks one sort of closing comment. So I'm going to start with you, Dr. Ihara. What do you want to say to doctors who are considering, not the doctors we just talked about who may be deciding against, but doctors who are considering, or patients who are considering using lecanemab? What's the short message you want to give them?
I respect for a patient's decision for such circumstances. I don't push hesitant patients to treatment with lecanemab.
And Dr. Helliston, what's your final message to clinicians who are thinking about it?
My message would be that this drug has been approved for over a year. It's not going to go away. Okay, it's here. And so if your question is, how much work is it going to be? How much of a hassle is it going to be? Yes, it's more work. Yes, there's footwork that has to go with it and infrastructure that has to be placed. But this is with us, and we have to be willing to move to the next era with treatment of Alzheimer's disease. This is a new era, and we need to move on with it.
Dr. Schindler, last word.
I think the key is really personalizing care for patients and thinking about what is best for this particular patient in front of me. And for some of those patients, that's going to be anti-amyloid treatments. That's their best shot for having a slower rate of decline and extending their years of productive life. And for some patients, it's not. And I think that for physicians that are considering it, it is a lot of work. But again, I think most physicians became physicians because they wanted to help patients. And I think that these drugs are the best way to help some patients.
Dr. Suzanne Schindler, Dr. Wendell Helveston, Dr. Ryoko Hara, thank you for joining us. Thank you for your commitment to patients, for your commitment to Alzheimer's, for understanding what an awful disease this truly is, and for trying to do something about it. And for those of you who watched, thanks for joining. If you have any questions, email us at usagainst-Alzheimer's. Thanks.
Thank you, Russ, and to all our panelists. In just a few moments, our next panel will discuss the role of community-based public health in combating dementia. That's coming up at 3:30 Eastern. Please stay with us.